Ladies and gentlemen, before I engage our panel, I just would like to express my tremendous appreciation to Laura and the Rutledge Foundation for the privilege of serving as honorary chair. I also had an honor to actually speak at this event 4 years ago. Seems just like yesterday. And when I was looking back over the remarks I made at that time, I was thinking about some of the challenges that existed, most of which still exist, in focusing on the management of adolescent and young adult cancer patients. But I also have had the chance to reflect upon some of the progress that has been realized. We have here in Fort Worth now a tremendous community-based network built around the Fort Worth AYA Oncology Coalition, which is providing utterly unique leadership, bringing practices, academic centers, hospitals, and other organizations together with the common purpose of improving survival for young people with cancer and enhancing awareness about what a big problem this really is. So I know there are many of you in the group who represent Fort Worth AYA OC, and I tip my hat to you for your initiative and your leadership. And the fact that we now have a place that these young people can call home when they're a little too old to be at Cook Children's and maybe don't quite fit into the regular units at the adult hospitals. There's a unit at Baylor Scott & White that is utterly remarkable, dedicated entirely to this patient population. So that's one of the areas of progress that I think that we can look at as real evidence of improvement. The theme of today's session, which is going to be quite brief, unfortunately, but may whet your appetite for more, which I'll tell you about towards the end, is accelerating the path to personalized cancer therapy. And that is what we all dream of, those of us who care for cancer patients, those who are afflicted themselves or as family members, how to be more specific in treatment to have fewer side effects, better responses, better prospect for a healthy long-term survival. And I know that each of our panelists here in their particular area is focusing on that challenge with some very encouraging results. So, without further ado, I'll begin by welcoming back to Fort Worth and to the Rutledge Foundation Hearts of Gold Luncheon Dr. Jason Houston, who has become a terrific friend of us here in Fort Worth, and he represents a true spirit of collaboration, which is the key to success in improving the lives of these folks. Researchers and clinicians must work together, and Dr. Houston is a tremendous proponent of such collaboration. So, Dr. Houston, please describe for us the Ferris D. Virani Ewing Sarcoma Center and the work going on in your laboratories, and also give us a little insight into what makes you tick and what led you into this field of research yourself.
Thank you, Paul, for the introduction. I also want to thank the Rutledge Foundation for this special opportunity to come to the luncheon and talk to you, everybody here, and of course thank everybody here for attending and taking the time out of your busy schedules to listen to our insights or non-insights, we'll see. So I'm going to answer the latter question first. So I got interested in pediatric oncology, during my medical school and then obviously into residency, but specifically I got interested into pediatric bone tumors and sarcomas during my fellowship, and it was while I was at the Johns Hopkins NCI doing my fellowship that I realized this was a subgroup of patients that we really hadn't done much for. This was at the time I was training, several years back, but we really hadn't made much progress in these groups of Ewing sarcoma and osteosarcoma patients, especially for those with advanced stage disease, such as metastatic disease or disease that has spread to other locations in the body. And being at the NCI, especially the National Cancer Institute, everyone thinks about the National Cancer Institute as just being the government agency that helps fund research, which is true, but unfortunately not enough for pediatric research. But they also have a hospital, and so the NCI actually has a small hospital there that we would, as fellows, be responsible for, kind of taking care of the patients, being the primary provider of the medical care. And the NCI was a special place not only because it saw patients from all over the country, but it also saw so many patients from all over the world. And if patients from any part of the country could find their way up to the NCI independent of their financial resources, and if there's an open trial, they would be automatically be able to go on that trial for their care. So we'd have numerous patients from Central America, South America, and other locations across the country where literally the families would and the communities would support, get enough money to give them a bus ride or get enough money for an airplane ticket up to DC and the NCI to get on a trial. And at the NCI, we had, we saw a large number of sarcoma patients. We had some of the leading experts in the world, Lee Hellman and others at the NCI, who really had formulated a number of fantastic trials or attempted trials, for these sarcoma patients. So it was really during that time that I got very interested in that population of patients as, hey, what can we do for these patients that are coming in that we really haven't made much progress for? And that led me towards my academic career now at Texas Children's to continue the research into sarcoma biology, Ewing sarcoma, for example. And it was just about 4 years ago that we initiated the Forrest E. Virani Ewing Sarcoma Center. And this was really kind of truly a mutual collaboration, not only with other investigators at TCH, but also with the family. So this was a young boy, 9 years old, that had been diagnosed with metastatic Ewing sarcoma. And the family was extremely passionate about how can we make a difference for not only their child, obviously, but also for other children afflicted with Ewing sarcoma. And so in February of 2014, we opened the Forrest E. Virani Ewing Sarcoma Center. And our goal was to make it a comprehensive center where not only are we trying to do some of the cutting edge research into Ewing sarcoma, but also the psychosocial, kind of the full gamut of patient care, leading the patient from diagnosis all the way through, obviously, to our goal of long-term survivorship. Making sure the family is supported, making sure all the resources are there, both from a medical side of thing, but also from, personal and family side of thing. And so that's been a truly, rewarding experience. It's also allowed us as a center to open up, collaborations, up here with Dr. Bowman and his team, other investigators up here, to hopefully advance some of the research that is ongoing within Ewing sarcoma.
Can you just elaborate on what you see as the biggest challenge that faces Ewing sarcoma patients and what you're working on to overcome that?
You probably ask 10 different investigators, you'll probably get 10 different answers, but I think for us personally, what influenced me during my training was, again, seeing patients with advanced disease and or relapse, meaning that they didn't respond to the therapy or they had advanced disease already up front, meaning disease that has spread to other locations in the body. So, our abilities to still treat these patients that have metastatic disease or patients that do not respond or relapse, from their disease is extremely difficult. And that's one of our areas of interest. And again, there's multiple areas, personalizing every individual along the way, and their treatment is definitely a goal, nationally as well as internationally. But for us, that's kind of been part of our focus, is trying to see what we can potentially do for these patients that we know up front have a poor prognosis, unfortunately. So,
thank you. Let's pass the microphone to Dr. Richard Gorelick now. Dr. Gorelick is making his first trip to Fort Worth. He is, but not his last, I'm sure. And he can tell you a bit more about his background, but he has recently relocated to Texas from New York, which has been his home for many years, to take on a leadership role at MD Anderson. And of course, at MD Anderson, being part of the Texas Medical Center, you and Jason, you're neighbors, right? So I hope you get along well together. Yeah. Complimentary and collaborative and all that sort of stuff. Great. So, Dr. Gorelick, please tell us also what led you into this field of work to try to overcome some of these very challenging cancers in young people, and what you hope to accomplish in your new position as a division head and chair of pediatrics at MD Anderson.
Sure. Thank you all for being here, and thank you for having me here. Indeed, it is the first time I've been in Fort Worth. So, Thank you. Me, even though I'm sort of in this leadership role, I am somebody who's never particularly liked public speaking. So I'm just going to pretend I'm in my living room and, even though there's a couple of hundred people here and it's a big room, we'll just forget about that. So, I'm going to answer your question, but, my life is incredibly simple. So I can cover my whole career, including the movement of MD Anderson, in like 2 minutes.
Perfect.
I wanted to, now it's
Since
a
we're
challenge.
behind schedule
now I
anyway.
gotta try to do this. Now I got to try to do this. So, the reason I sort of say that is I went into pediatric oncology because I'm a cancer survivor. It's very straightforward. I had a synovial sarcoma when I was 13. Was treated in New York at Memorial Sloan Kettering. It was a time when the cure rates of those diseases were terrible, and I'm grateful to be alive and grateful to give back. So that's a very, very easy answer to my question. So here's, I went to a 7-year medical program that sort of goes along with this. Quickly did a peds residency up at Columbia. And I went to a fellowship at Memorial Sloan Kettering, a known cancer center. That's where I chose to train. And here's where the story becomes a little more complicated, if at all. Obviously, this is a 2-minute story. When I went into pediatric oncology, the reason I wanted to do it is I wanted to just care for patients. I wanted to be like the doctors that treated me. I wanted to be compassionate. I wanted to sort of, help families and the patients through it. I wanted to do what had been done for me. And that was sort of my trajectory. Hence, I went to that 7-year medical program, did everything I did very quickly. But then I got to fellowship. And in part of fellowship training, you have to do research, meaning it's required, meaning it's not something that's optional. I viewed that as something I have to get through, get done with it as quickly as possible. But like everything else, good kid, trying to do what's right. So I took it seriously and paid attention to it. I had a phenomenal mentor. It was a mentor who basically was a clinician who was in the early days of chemotherapy and worked on lymphoma, a guy by the name of Joe Bertino, sort of famous name in the field. And what he would say to me is, I'm a doctor just like you. I care about my patients. And the way you help one patient at a time is by caring for them. The way you're going to change the field is through research. And it's research that's going to move the field forward so that the next patient isn't in the same place as the one who you're treating today. He said, when you have 100% outcome and everybody's perfect on the back end, you stop research and be a doctor. But until then, research is an important part of it. I took that message seriously. I started my own laboratory like 2 years after training, and that's something I've continued to do. I moved up the ranks where I was. I'm a lifetime New Yorker. MD Anderson really is a place where there's a tremendous academic environment. Yes, we are going to be collaborative. I appreciated going to the Ewing Sarcoma Symposium that was just conducted at Texas Children's, because research isn't about curing a patient at any particular site. It's about curing everybody who's facing the illness. And really, it's MD Anderson, that I thought was a special place in terms of the resources they had in terms of research and clinical trials that were going to be the path to moving the field forward. To be honest, I'm being embraced by Texas, and I love Texas, but my family's, other than my immediate family, is back in New York. So for me, it was about sort of the opportunities afforded by the academics that are at that place to move the field forward. So you asked me where we're going. We're going towards academics. We're going towards enhancing clinical trials, bringing novel immunotherapy approaches, novel targeted therapy approaches. And to me, in addition to caring for patients, that's the most important thing we have to do.
Can you tell us just a little bit about your own specific area of research that you've been working on?
So, I had a synovial sarcoma, but, I wanted to be a sarcoma doctor. My area of focus within sarcomas specifically became bone sarcomas. I actually work a little bit more on osteosarcoma than Ewing sarcoma. That's the focus of my laboratory. In sort of national cooperative groups, Ewing's and osteo go together. So I take care of patients with a full spectrum of sarcomas, but that's my area of focus.
Thank you. I'm going to slide back a little bit because I think Dr. Pneumonitis' cheering section is over there at the Mary Crowley table. So our third guest is Dr. John Pneumonitis, who is a closer neighbor from Dallas, and he's been working on clinical research in collaboration with Texas Oncology for over 20 years, and clinical trials that are run by the Mary Crowley Cancer Center, with whom the Rutledge Foundation has a close relationship because of the connection that developed through Carly. And Dr. Maurizio Gazzoli is over there, who's also been very much instrumental in this from the pediatric standpoint. So what we hear so much about these days in the news is about the immune system. And those of us that have been in the practice of oncology for many years, as I have always thought that was the holy grail to be looking for, some way to activate or turn on a person's own immune system to kill cancer, to nip it in the bud, ideally, or if not that, at least augment the effects of chemotherapy and radiation so that disease that responds but relapses may now respond and stay responded. And I think this is the work that Dr. Pneumonitis is spearheading, and I'd love for him to tell us a little bit about that.
Sure. Well, thank you, Paul. I appreciate it. And thank you guys for everything, too, and everyone here. Because it's through meetings like this that we have an opportunity to engage and move the field forward. And that's where, in the same mindset that everyone has up here, to move the field forward in a way where it can help patients. That's what was my bug. When I grew up, I thought football was the whole thing, actually, and played in college. My dad said, no, you got to go learn something. And so I was trying to think of the most challenging field to go into, and oncology seemed to be it. So I'm an adult oncologist. I had a chance to train with Don Thomas and did a lot of work with Richard Gibbs on the genome sequencing and on the basis of immunology and how it affects cancer. Much of the work in the early days was with graft versus host disease in the marrow transplant field, actually. Then I had a chance to come into Dallas and work with Mike Reese and Texas Oncology and bring in a clinical trial program. And during that program, one of the exciting directions were how to excite the immune system, how to develop personalized approaches where the immune system would be relevant to that individual patient, because each cancer has its unique attributes and unique antigens and unique signals. And so from that perspective, Ewing sarcoma is quite a dramatic tumor from the standpoint of the molecular biology. We know the driver gene of Ewing sarcoma. We know the cause of it. With many cancers in many adults, we don't know the cause of the cancer progression. We don't know the driver gene. So our program is focused on personalized therapy and unique genetics of cancer. But in Ewing sarcoma, the opportunity is known that this EWS-FLI fusion gene is clearly related to driving that normal bone cell to become a cancer cell and then basically deteriorate our poor patients. And so in the proof of principle of that, we set up an immune trial first to put two genes into the patient's own tumor cells and to then turn on the immune system and find ways of turning on the immune system. I've been involved in over 600 trials and have had a lot of interaction with FDA. And so to enable them to understand the value of this, the importance of this, and the biology of it is a critical part of moving the field forward. And so they were convinced that this immunotherapy is helpful for Ewing sarcoma. And last month had an opportunity to talk to them in great detail, where they've now approved the database for a registration trial. If this trial is successful, we see it in the patients, but we want to do things that can help all patients. So if this trial is successful, it'll be a new mechanism to treat Ewing sarcoma for first recurrent disease. And the guys here are all involved in it. And so I think it's an exciting opportunity for us. But sometimes the immune system can't cover the whole field. Sometimes we can just palliate cancer, that delay progression. And so the other aspect of the approach is identification of that driver gene that I was telling you about. We also discovered a technology it's called bifunctional RNA interference technology, and we can deliver that to the patient. And in reviewing the animal database and some of the initial studies that were done, the FDA also agreed that this is something that's important to move into the field. And so that's a trial that's ongoing now, again for Ewing sarcoma. And the vision is try to hit the cancer hard in the beginning with the molecular EWS targeting, and then try to engage the immune system that'll last a long time to prevent it from coming back, and sort of try to bring this cancer into an area like diabetes or hypertension, where a lot of people, we haven't cured that disease, but we can keep it under control. And so that was the direction of the personalized therapy with Ewing sarcoma that we constructed.
So do you see this type of approach ultimately replacing traditional cytotoxic therapy, or will it be a complement to? How does it fit in the long term once you get some of these techniques proven in clinical trials of relapsed patients?
Ultimately, I want to see the results of this trial.
Okay.
But as you understand, we've had some very good successes already, and we've had some situations where we couldn't help the patient, and we're still trying to learn what is it. I mean, as Laura knows, with Carly, that made her such a dramatic, responsive patient to this therapy, and other patients where we couldn't help. And so we're trying to still learn that. And that's where the work of all of us combined is so important to understand the biology of the cancer. And I think as this registration trial is going on, it's going to take 2 years. More discoveries are going to be made. And at that point in time, did we statistically significantly help these patients? And have we learned more about the biology to now? Should this be right in front line and replace chemotherapy, or should it be something that after chemotherapy it's used to support the patient? We don't know yet for sure.
Very good. I'm sure that many of you are just bursting with questions you'd like to ask, but you can't. I'm sorry. Because we don't have time. However, I'm sure that our guests will be open to being approached after the session if some of you would like to come up and shake hands and say hello and so forth. Before I introduce our featured speaker, I would like to ask you all one question. And the question is, raise your hands if you know where UNT Health Science Center is. Okay, that's pretty good. Okay, how many of you think it's in Denton? It's not. The main campus for UNT system is in Denton. And of course, you have Dallas campuses also. I'm mentioning this because it's just up the road, just up that little red brick road at the corner of Camp Bowie and Montgomery. And I'm very pleased that our featured speaker and 2 of our 3 panelists are going to be speaking there this evening. This is an event that is organized and hosted by the Oncology Student Interest Group of UNT-HSC, Texas College of Osteopathic Medicine, the 6 officers of whom are here today and have been your volunteers. So I'd like to ask them to stand and be recognized. So if you find these topics really thought-provoking and you'd like to learn more about the science and some of the innovations that are underway, you are all invited. 5:30, Met Building, 1000 Montgomery Street. Parking is there. There's even going to be dinner. First come, first served. I'm serious. We can do this, right? Yeah, I hope so. The evening is jointly sponsored by that Oncology Student Interest Group, by the Rutledge Foundation, who are being generous with their time and support, and by the UNT Health Science Center Office of Advancement.